Hi, everyone. My name is Nityasri Sankar, and I am a third-year medical student at the University of New England. I've been working with Dr. Keena Thakrar, an infectious diseases and addiction medicine physician at Maine Medical Center, on a research project exploring infectious diseases in people who inject drugs and harm reduction service utilization. Today, I will be presenting specifically on hepatitis C infection amongst people who inject drugs and risk factors and injection practices associated with exposure to this infection. I have no financial or commercial relationships to disclose. So just to start with some outline and some objectives. The objectives for this presentation will be to review hepatitis C epidemiology and transmission, discuss specific injection practices that increase the risk of hepatitis C exposure and infection, and discuss opportunities for targeted harm reduction services amongst high-risk populations. So I just wanted to start with what is hepatitis C. So hepatitis C is an RNA virus that travels through the blood and ultimately infects the liver. Long-term effects of this infection include severe liver damage, such as cirrhosis, which is basically scarring of the liver, and ultimately can lead to liver cancer. Hepatitis C is a leading cause of death secondary to liver disease. Acute hepatitis C infection becomes chronic infection about half the time, and less than half the people infected can clear the infection on their own. So in terms of prevalence, globally, there were 71 million people infected with hepatitis C in 2015. In the United States, approximately 1% of the population, which is 2.4 million people, were living with hepatitis C between the years of 2013 and 2016. The rate of acute hepatitis C virus cases increased in 2018, with there being 3,621 new cases reported and 50,300 total acute cases reported in 2018. The prevalence of hepatitis C infection amongst people who inject drugs was 53% in 2016. So this is a graph just showing the rates of reported acute hepatitis C infection by age group between the years of 2003 and 2018. As you can see, around the years of 2012 to 2013, rates of acute infection started to rise, especially amongst people between the ages of 20 and 39, which would be the top two lines on this graph. So in terms of transmission, hepatitis C is transmitted via exposure to blood or bodily fluids that contain blood. Risk factors for transmission are listed here from most common to least common. Injection drug use is currently the most common method of transmission of hepatitis C, followed by birth to a hepatitis C infected mother and having sex with a hepatitis C infected person. Other less common risk factors include sharing items contaminated with infected blood and unregulated tattoos. Before 1992, the most common risk factor for transmission was the receipt of blood products and organs. However, this has become much less common since now blood is being screened for the virus prior to starting transfusions or donating organs. So this is an interesting graph that represents reported risk exposures and behaviors for acute hepatitis C during its incubation period, which is 2 weeks to 6 months prior to symptom onset. And the goal of this graph is to compare the prevalence of risk exposures. So the green bar represents the number of people who reported the risk behavior. The orange bar represents the number of people who denied engaging in the risk behavior. And the yellow bar represents the number of people who did not answer in each of these categories. As you can see, of the 1,182 case reports that contained information about injection drug use, 759 people, which is 64.2%, indicated use of injection drugs. And none of these other risk behaviors had a percentage over 50% of people who reported the behavior. So injection drug use is clearly one of the major risk factors for hepatitis C infection, which is explained well by this graph. Um, so I wanted to share some conclusions from some of the more recent studies that have explored hepatitis C infection amongst people who inject drugs. So there was a study done in Germany between 2004 and 2014, which identified low awareness about the risk of hepatitis C infection amongst people who inject drugs, suggesting opportunities for education regarding hepatitis C transmission and testing. Another study done between 2004 and 2014 in the United States suggested that integrated health services, including syringe service programs, MAT, and linkage to hepatitis C treatment may lower infection rates amongst people who inject drugs. So essentially, they were saying that the concept is if all of these services were in one place, then it may lower the risk of infection by just educating people about the risk of infection through injecting drugs. So this same study also concluded that early detection and treatment of hepatitis C virus can lead to better long-term outcomes and hopefully lower the mortality rates of this virus. So to get into some data about hepatitis C infection in Maine, so Maine has the 9th highest rate of acute hepatitis C infection in the United States, according to the 2018 Maine CDC hepatitis C surveillance report. There's been a 314% increase in cases since 2013, with 51.3% of the cases being people who used injection drugs. 35.9% of people were incarcerated prior to infection, and 35.9% were people who used non-injection drugs. So those are just some other statistics about hepatitis C infection in Maine in 2018. So this graph shows how the rates have been rising in Maine over the last 5 years, from 2013 to 2018, with a most recent increase between 2017 and 2018. So in terms of treatment of hepatitis C virus in Maine, in 2018, the state actually eliminated the Medicaid requirement for people to be opioid-free for 6 months prior to starting hepatitis C treatment. In addition to lifting the significant barrier, the Medicaid expansion in Maine under Governor Mills has greatly improved access to treatment. Most recently, actually this month, the Maine Department of Corrections agreed to expand access to hepatitis C treatment amongst people who are incarcerated. This is a really big deal because in 2017, only 3 out of the 580 people who were infected with hepatitis C who were incarcerated were provided with treatment. So that's a really low number out of all of the people who suffered from that infection who were incarcerated. So this new development could significantly reduce complications of the virus amongst this particularly high-risk population. So the specific research study that I've had the privilege of being a part of at Maine Medical Center is called the Rural Heart Study. And the study was developed because there was minimal attention being given to characterizing the utilization of harm reduction services in Maine, which is a state with high rates of injection drug use. In most recent years, the incidence of viral hepatitis and injection drug use associated infective endocarditis has increased in Maine, suggesting that people who inject drugs underutilize harm reduction services. The study was designed to provide information about the barriers that people who inject drugs face in accessing these harm reduction services because they are available. With this information, there will be an opportunity to design focused intervention programs to improve the uptake of these services and ultimately, hopefully, reduce the risk of injection drug use associated infections. So as a part of this overarching study, I decided to focus my attention on hepatitis C exposure, risk factors, and awareness of the infection amongst the study population. As I've mentioned before, the incidence of viral hepatitis in Maine has increased in recent years, with over 50% of cases being between 2013 and 2018 being attributed to injection drug use. The goal of this specific project was to identify specific high-risk injection practices amongst people who inject drugs in Maine and examine the association between these specific injection practices and hepatitis C exposure. The sites included in this study were Maine Medical Center, Maine General, Eastern Maine Medical Center, and Penobscot Bay Medical Center. And these 4 hospitals are located in counties that are high risk for HIV and hepatitis C outbreaks. Participants in this study included patients admitted to these hospitals with an injection drug use associated infection. And of note, we defined hepatitis C exposure as hepatitis C antibody positive based on lab results or through self-report. So in terms of data collection, we used a few different methods. So demographic information and laboratory test results were collected through review of the electronic medical record. For most of the bulk of the data, patients completed a survey through the audio computer assisted self-interview to assess details regarding injection practices and attitudes and knowledge surrounding drug use. As part of this survey, the Bacterial Infection Risk Scale for Injectors, which is shortened to BIRSI, was used to quantify high-risk injection practices. So patient demographics and characteristics, patient attitudes, and injection practices were examined and stratified by hepatitis C exposure using descriptive analyses. And in addition, a logistic regression analysis was performed to examine factors that were associated with hepatitis C exposure. So to get into the results of these analyses yielded some specific information regarding demographics and risk factors associated with hepatitis C exposure. Overall, 75% of participants were identified as having hepatitis C exposure. 57% of participants exposed to hepatitis C reported homelessness. And in addition, participants exposed to hepatitis C were more likely to have bacteremia or sepsis during their hospital stay. So those were just some initial results from the demographic analyses. And now to get into some of the results that are more specific to injection practices. So first, 40% of hepatitis C exposed participants reported infrequent use of a needle exchange program 3 months prior to admission. Although not the majority, this is still a significant number of participants exposed to hepatitis C who are not regularly using a needle exchange program. Participants not exposed to hepatitis C perceived low likelihood of contracting this virus due to injecting. Even though these participants hadn't yet been exposed to hepatitis C, this identifies a population of people who could be better educated about their risk of contracting this virus from injecting, especially if they aren't injecting safely. 57% of people exposed to hepatitis C reported using a new needle about half the time or less, which also indicates room for improvement. 71% of hepatitis C exposed participants reported infrequent use of alcohol pads prior to injecting, and 67% reported infrequent hand washing prior to injecting. Overall, a higher bacterial infection risk scale for injectors, the BIRSI score, so a higher BIRSI score had higher odds of exposure to hepatitis C, with an odds ratio of 1.48 and a 95% confidence interval of 1.1 to 2.04. So these are some pretty significant results in terms of specific injection practices and the risk for hepatitis C exposure. So this is just a graph that depicts some of the injection practices that are included in that BIRSI 7 score that I was talking about earlier. So as you can see, there is infrequent use of alcohol pads and hand washing, and high incidence of skin popping and muscling prior to injecting, which are both problematic injection behaviors. Although a significant portion of people report either always or mostly using a new needle, there are still about 50% of people who report less frequent use of a new needle each time they inject, indicating that there are continued opportunities for improvement of educating people about the importance of using a new needle each time they inject. So just to talk about some limitations of this study, obviously there are some potential inaccuracies when you are using primarily self-report data due to recall bias. And since a lot of these patients were pretty sick in the hospital, there were a lot of incomplete survey reports, which just limits some of the data that we have from people. So some of the major conclusions that we drew from this data were that first, a higher BRCA 7 score was associated with hepatitis C exposure, indicating that, as we know, unsafe injection practices lead to a higher risk for hepatitis C exposure. Secondly, there was a lack of specific injection practices such as alcohol pad use and hand washing in participants with hepatitis C exposure. So these hygiene practices in particular were kind of low or lacking in people that were exposed to hepatitis C infection. And lastly, while not the majority, a significant proportion of people exposed to hepatitis C did not use a clean needle each time they injected, which, as we know, is problematic. So based on this data, we can see that there are definitely opportunities for more education regarding hepatitis C infection and the risk factors for transmission. Specifically, it would be helpful to expand education regarding hepatitis C infection and the long-term sequelae of the infection, since it is a leading cause of death due to liver disease. For people who utilize syringe service programs, it is important that we specifically encourage alcohol pad use and hand washing prior to injecting, just to emphasize the importance of these hygiene practices that we found to be lacking. And in addition, we can always continue to emphasize the benefits of using a clean needle during each new injection. So just to conclude this presentation, I want to acknowledge some people, the study participants, obviously, all the research personnel involved with the Rural Heart Study who've been working really hard on making this study possible. Specifically, I would like to thank Kim Murray, who's been a great help on the statistical side of this and has used her expertise to help me with all the analyses, and Deb Burris for her work in study coordination and helping me learn the data collection aspects. And then lastly, of course, I would especially like to thank my research mentor, Dr. Akina Thakarar, for bringing me into this project, mentoring me, and giving me the opportunity to be involved with infectious diseases and harm reduction work, which are both fields that I'm very interested in and hope to continue to be a part of. And the research reported here was supported by the grant U54GM 115516 from the National Institutes of Health for the Northern New England Clinical and Translational Research Network. And that is the end of my presentation. So I welcome any questions, comments people may have, which can be posted in the Q&A chat box. And I would love to hear people's thoughts about this presentation. In addition, any suggestions that people might have about how we can use this data to improve harm reduction in the state of Maine, and just for some more specific ideas maybe on how we can use this data to help the population of people who inject drugs. So thank you so much, and thank you for coming to my presentation.